Again, I have no conflicts of interest for this presentation. I do want to start off by acknowledging my contributors to what I'm going to present. We conducted a systematic review on nutrition long COVID, and Julie Long is a research associate with actually a PhD epidemiology student now. And then we had Dr. Muramoto, Dr. Leggett, who are family practice physicians. And then Christy Piper was our librarian, Dr. King at the University of North Carolina, and Dr. Grossman at Stanford. And then Shari's a dietitian who brought in actually more of the nutrition perspective to this review. So the objectives today, it's going to be a little bit academic, but as you listen to it, think about the applications to what I'm saying, because I want to just present results from papers, but I do want you to understand that how do we implement them? That can be part of our discussion afterwards. So I want to highlight the results from the systematic review, sort of like you would see in the background of a paper. And we focus on some specific nutrients. And the primary outcomes I'm looking at are olfactory syndrome, so there's more papers on that topic. I'm also going to look at fatigue, which includes ME/CFS, the myalgic encephalomyelitis, and chronic fatigue syndrome, mental health issues, and then cognitive outcomes too, which all sort of some of the major issues you see with long COVID. Let's see what else. Oops, I'm trying to think about how I go backwards now. There. So just quickly, when we did this review, we do a regular systematic review. We used 5 databases. We ended up, sorry about this. We ended up with about over 3,500 papers. Then we got actually we excluded 3,000. We had 5,000 records screened, but we really ended up with 49 studies that I'm going to use for this presentation. I can show you. You should have access to these slides, and you can see why we just discarded other papers. Just kind of tell you where these studies were coming from. The studies, first of all, 11 were cross-sectional studies, RCTs, randomized controlled trials. 11 were cross-sectional. We had prospective studies, lots of retrospective cohort studies, a couple case series, and pre-post only studies. And interestingly, most of the studies were coming out of Italy. And if you remember COVID, when it first hit, Italy was really hit hard with COVID. And it's not surprising they have more of the papers on long COVID because it's obviously at the top of their mind. The US, there were some multi-country studies, Brazil, Egypt, Taiwan, and the 18 countries, basically got one study done in each of them. So the 49 papers, here are some of the issues. The associations were were cross-sectional longitudinal cohort studies, and we had retrospective studies. But you see that only associations, 3 impacts on long COVID on nutrition, 5 nutrition on preventing long COVID, 25 were interventions for treating long COVID. These were the outcomes that were being looked at. And these were the nutrients or the dietary pieces that were being studied. So people didn't study everything, but vitamin D was a very popular nutrient that was being studied. Also, just multivitamins. You'll see this PEA and lutein about olfactory symptoms and just dietary patterns. So these were the types of nutrients that had been getting studied. Just some caveats about all these 49 studies. Mostly were white subjects, and mostly were outside the US. So that has an issue about how one develops long COVID, something to think about. Over the time of these studies, we had different virus variants, and so that could be an issue. So we're not very consistent on that. Vaccination status was not always controlled, and we know that vaccination status helps lower your risk for long COVID. There's good work on that. No, the severity of the initial infection was not always accounted for. So again, something else that's related to long COVID, but you can get long COVID even when, as you know, without a severe infection of long COVID. You don't have to be hospitalized to end up having long COVID. Not all studies controlled for confounders, and not baseline nutritional status was not always controlled. So one of the things as a nutritionist is when you do an intervention, let's say you give iron or zinc or vitamin D, you want to know what that vitamin A, zinc, and vitamin D status is before you start the intervention, because if someone's not deficient, often you won't be able to improve a deficiency. So you always want to know what that baseline value is. So I'm going to start going through the types of symptoms that were studied in these papers. And so I'm going to talk about the olfactory symptoms first. And you see there was lots of negative studies. There was one, this was cross-sectional, and the Cotton study, this on the right side of your screen, they looked at diet, BMI, vitamin D, fruits and vegetable consumption, didn't find a difference by those factors related to long COVID or to olfactory studies. Another study, a little bit larger, Figueiredo, did provide alpha lipoic acid for 12 weeks, but both groups significantly improved. They didn't really see much of a difference between that and the placebo group. Lerner gave 2 grams of omega-3 fatty acids to see a slight improvement at 6 weeks, but not a longer-term average at 700 days. And the other thing about giving 2 grams of omega-3 fatty acids, I've been involved in a study where we were giving 3 grams of omega-3 fatty acids to help prevent postpartum depression, to help manage postpartum depression. So one of the issues with the Lerner papers, they may just not have given enough omega-3 fatty acids to have an effect, a statistically different effect. And then Garcia gave a combination of different supplements over a 3-month period with placebo, and they showed no difference. But the studies that did show a difference are the ones I'm going to talk about next. So De Ascanio did a randomized clinical trial of olfactory dysfunction. This was through rehabilitation therapy. And one of the important things about these studies is that they all do sort of olfactory training. And I'm a nutritionist, so I didn't really know exactly what that was. But it's really helping them practice smelling well. They do stimulation through sniffing sticks, administered twice every day for 10-minute sessions for 30 days. And then that's the control. And then the treatment was the daily treatment of PEA and lutein. And you can see on the right side here that in the control group, there's very little difference. And the treatment group, even though they started lower, which is a concern, they did significantly improve with the treatment of PEA and lutein. This was a very small study, only 7 in the treatment group and 5 in the control group. Cantone did a little bit larger study. They had 23 in the olfactory training group, 17 that got a PEA ultra processed micronized supplement, and lutein, 17, and they had an alpha lipoic acid group. And if you look over here, you see the control groups didn't change, but the alpha lipoic acid improved a little bit, but not significantly. But the PEA group, before and after, had a significant improvement. And when they combined it, they also, with the alpha lipoic acid, it also improved. So it looks like PEA, lutein, may have a significant impact on improving smelling for those patients that have problems with long COVID. So what were these chemicals? Just so you give you a background, PEA is an endocannabinoid cannabinoid-like lipid mediator with anti-inflammatory, analgesic, antimicrobial properties. You can get PEA from coffee, soy, peanuts, walnuts, wheat flour. Alpha lipoic acid is an antioxidant. You can see some liver, kidney, heart, brain, and yeast. Plant sources include the spinach, the broccoli, tomatoes, as you can see this, rice bran, seeds, like flaxseed and pumpkin seeds. Lutein is a flavonoid with antioxidative properties, anti-inflammatory properties, and it comes from radishes or peppers, chicory greens, celery. The issue is that consuming it would not be at the same level as the supplements that they gave. You have to eat lots of these foods to probably get to the same level as supplements, but on a longer term, it might be helpful. So, these are short period studies. So you take it for a longer period. Over time, they may be helpful with olfactory outcomes. Now, Sosa did an interesting study where they sort of tailored each of the approaches to 4 different groups of patients. And so they had people who had a nasotopical CT, a multivitamin B repletion project. One had nasotopical CT. Another group had intranasal vitamin A and E. And another group had no adjuvant therapy, just the olfactory training by itself, when they did not intend to perform any additional therapy. And so you have these 4 groups, and again, not large studies. Training alone was 14, that's this group here. This is their improvement score, and you see that with the tropical corticosteroids, they had an improvement. They had a little bit of improvement again with the multivitamin repletion, and they also had the same amount of improvement with the intranasal vitamin A and vitamin E. So you see there seems to be some positive effect by giving the multivitamin and the vitamin A and vitamin E. And this was a short course oral vitamin A aerosolized diffuser training on it. They gave a large dose of vitamin A, oral vitamin A of 25,000 international units for 14 days in combination with training, a control group, and they used 2 tests to kind of see the improvement, the butanol threshold test and the smell identification test. And you see here, here's the control group, no big change. In blue, no big change in the standard group. But when you look at the butanol threshold test, the combination group that got the intervention plus the N goes from about 3 to about 6 as an average score on the BTTS score, significantly improved, better than the other groups. And same with the smell identification test. You see a significant improvement with the combination group, but not much difference in the other 2 control groups. And then you look at the end of treatment and functional outcomes. They looked at functional outcomes, which I thought was interesting. Did functional MRIs, and they actually show that this treatment actually stimulates front of the left inferior frontal gyrus of the brain, which is interesting to me because I didn't know what that part was of the brain, but it's actually related to function, executive functioning and other things, not necessarily related to smell. So I just found it interesting. It was a new type of, if someone's a neurologist knows more about brain metabolism than me, it'd be interesting what's the reason for this strong correlation of 0.858. So I want to talk about fatigue. And I wish there had been more studies on fatigue because ME/CFS is a very common long COVID sequelae. And the problem tends to be the way the studies were done, and they weren't done well. So this is cross-sectional by Townsend, no correlation after adjustment between vitamin D levels and childhood fatigue score. This is a correlational study. This study by Turko Stiolika was 2 commercial supplements with arginine, 3 months follow-up group, but they have no controls. And you see this is a problem with several of these studies. Just before and after, you have no control. You have no idea if they would have gotten better 3 months later, even without anything. So without a control, and just looking at pre and post, I can't put any faith in any of these studies myself. Same with Gayuso. 28 days showed improvement, again, no control. looked at it between those who were greater than 60 and less than 60 years of age. It actually had a better impact for those younger than 60. The Grundler paper just had them fast for 6 to 16 days. And it says they improved fatigue and breathlessness. And I think as someone who thinks about intermittent fasting, this chronic timing of eating, it's an interesting concept. But with no control, you have no idea if they would have gotten better anyway. So these other 3 studies were good studies, and I'd like to go over them that did show a positive outcome. Let's see what's going on here. Okay, the NOCI study. This they wanted to give zinc. They gave an oral supplement, and it included things like zinc, echinacea, rosehip, vitamin C. It was they gave propolis, which is from beeswax, and galactin, which is a type of flavonoids, and royal jelly, which I forget what that actually provides. But the intervention, it was a randomized control, double-blind study, good methodology, and they showed significant increases in vitamin D levels with the treatment, because some of these had vitamin D in it too. I forget where it's going here. But you can see here, if you look at the fatigue questionnaire, the before and after group had a decrease in fatigue here. Not much difference in the Epworth sleepiness scale, but in the fatigue scale, it definitely seemed to help the fatigue, giving this multiple supplement. The Landy also was a multi-component nutritional supplement to really sort of improve muscle mass to help fatigue. This was a controlled match study from electronic medical records. They had 33 people per group. So again, it wasn't randomized control, but it was a little bit better. At least it was better than just no controls. And you look at this intervention for the supplement that they provided. This is the percent change in the hand grip. You can see the control group, the intervention group, the hand group, intervention group, they improved by 21%. The hand grip, the skeletal muscle index improved by 8%. The chair standing test can increase by 13% compared to 2% for the controls, 5% for the 6-minute walking test, and the quality of life score were significantly better. So it really looked like this supplement helped. And I'll go back to it just to understand what it is. You can look up the Landy paper as far as what the supplement is. I forget if it was commercial or not. And then they look at the actual values. I can skip over the values. You just saw the graph on this. So now we're talking about cognitive outcomes. And cognitive outcomes, most of these wasn't necessarily brain fog. Some of it is depression. And I guess that gets into the mental health one, but some of this might have been also brain fog also. We'll get to the details in a moment. The Tomasa paper, Gible paper, that was a multi-nutrient supplement for 14 days, and then they measured outcomes after 180 days. Seems like a big gap between the time they stopped the supplement and they did the post-test. And so they showed no difference. The Hussein paper had lots of people, 219 post-COVID patients, 84% of them, this was done in, I think in Egypt, 84% had low vitamin D levels, but no association with neuropsychiatric symptoms, but only 10 had normal levels. So I think there wasn't a range enough of high levels to show a difference on vitamin D. Everyone was too low to show a difference on this idea of neuropsychiatric symptoms. The Rosato paper was a commercial multi-nutrient supplement. It had significant improvements after 28 days with a child questionnaire to measure mental fatigue, but again, no control group. And so it's again one of these pre-post studies. So I don't have a lot of faith in having this be significant, because you need to know what would have happened with another comparison group. Now we'll go over the positive studies. The Morello paper These were all hospitalized for COVID-19 infection. 98 were invited to be in the study. This was looking at them 3 months post-discharge, which is sort of a definition if you had symptoms for a longer period of time for long COVID. 57 said they would accept whatever treatment was being given, which is this PEA again, the ultra-micronized PEA, improves depression, and you'll see this. And that's the intervention, 600 milligrams twice a day for 3 months, post-discharge visit at 6 months. And they use these different outcome variables, analog scale for well-being, a self-rating for depression, fatigue, visual analog scale for pain, strength with assistance, or kind of covering lots of different outcomes actually. And the global improvement was defined as the improvement in at least 3 of these types of outcomes. This was the multivariate logistic regression analysis. If you got the supplement or not, and they controlled for sex and age, and just in the model seems to make, and this is the global improvement score. So you had 3 of these outcomes, or you did not have 3 outcomes. So they dichotomized the patients into having 3 or less of those variables. And then they looked at strength in walking. Again, it was significant. It was significant for fatigue, a little bit less, 0.059. The well-being scale was improved. The analog scale for pain was improved. And the self-rating for depression, all were significantly better for those who got the PEA. Okay, another study, again, these are random. This is why these are good studies, why I'm presenting them to you as the outcome ones. The effect of an 8-week high-dose vitamin D supplementation on fatigue and neuropsychiatric manifestations. So it was a double-blind, randomized, placebo-controlled trial, 80 patients, 40 per group. They got 60,000 international units of vitamin D weekly versus a placebo. The average age was 34, 77% were women. All had received at least 2 COVID vaccinations, very well controlled in that respect. Only 3 had been hospitalized, and they compared adverse outcomes, and they were not significant for giving them such a high dose of vitamin D. If you look at the coefficients of improvement, first of all, let me make sure this is, they were looking at, you're giving vitamin D, so they want to know, did they take the vitamin D? Did the vitamin D have a physiological effect before you looked at long COVID outcomes? So they showed a significant increase in vitamin D levels, in CRP levels, and inflammation markers did not decrease as much. And vitamin D level, CRP did not decrease very much, but the vitamin D level improved. And then they started to look at outcomes between the vitamin D and placebo groups. And you see that the fatigue scale was significant. The Pittsburgh Sleep Quality Index was almost significant. And probabilities are probabilities, right? 5 out of 100 times, you think it might be significant. You had the ACE, cognitive examination. Depression did not improve that much, but also the anxiety scores significantly were better. And then one thing they didn't really adjust for was multiple testing. But again, they didn't do that many different tests. So this is also really interesting. We had 3 papers using the TriNet X database. I'm not sure if you're aware of this database. It's a database that contains data over 300 million patients across 24 countries globally. And the papers that were being written using this TriNet X database were mostly coming out of China. You can see Wu wrote 2 of them, Liu had 1, and then Li had another one. And what I found interesting in these papers is these are large studies that they use propensity type matching to match those with long COVID and those without long COVID, and then do comparisons with nutrition between those 2 groups. And so this was one with, in 2023, patients, 15,000 patients with and without nutritional deficiency anemia. I don't know why this keeps changing. The nutritional deficiency anemia group was associated with post-COVID conditions, so that's important to understand. The second paper was looking at 300 non-hospitalized patients. Prior vitamin D deficiency was associated with ED visits, hospitalizations, and death, but not necessarily long COVID conditions. Liu, brain behavior and immunity paper looking at omega-3 fatty acid in these levels of patients with and without long COVID. And when they took supplementation, significantly decreased the risk for depression, anxiety, disorder, insomnia, and many other symptoms. Lots of covariates and subgroup analyses were part of this paper. And then the Lee paper was looking at just malnutrition using ICD codes. And they also show that if a person is malnourished by whatever, like low BMI, whatever you want to be looking at, they also are at greater risk for having long COVID. So this is sort of a summary slide of what those conditions look like. And I just want to say that, I think vitamin D was consistently more positive across the different symptoms, which I think, if you give, and there was also papers that showed that it didn't have lots of side effects. So I do think vitamin D supplementation may be helpful. The omega-3 fatty acids were a little bit helpful, although I forget if I have the codes here. Omit that there was no significant difference. Negatives would have been that there were, these are the number of studies that were done in parentheses. And so you see some differences, especially with vitamin D, even some vitamin C studies, although they often were combined with arginine too. The PEA definitely helped with smell, lots of strong studies on that. Here's the arginine and vitamin C, had some positive effects, but not very many studies. Taurine, a little bit on global associations. The supplements, the problem with those is they're all different types of supplements, but there did seem to be a propensity for a variety of different supplements to help prevent or manage global associations or MECFS. There was an interesting study, again, on fermented caricapaya and morinda, which had help on fatigue. Hydration was important. Fasting, it just wasn't a good study. Dietary pattern in one study, but it wasn't very strong. And then the malnutrition. So this is sort of a summary about how I think these nutritional compounds or components are related to long COVID. Here's my concerns. Most studies were of poor quality, except for some of those RCTs, some of the matching that was done. The definition of long COVID was not consistent, given the National Academy of Medicine definitions, variations in study designs, and how outcomes make comparison studies difficult. Some studies had no controls or only pre-post. Many studies didn't have baseline, as I mentioned earlier. Didn't measure dietary sources of nutrients when you're giving them a supplement. Well, what else are they eating was often not measured. Nutritional assessments varied. Nutrition often included with other interventions like the olfactory training, and doses for interventions were not consistent. So again, associations appear to be specific for each nutrient. Long COVID symptoms, so it's not just one thing. The PEA, lutein, olfactory training seems to be a promising for anosmia. Adequate vitamin D levels seem to be helpful for preventing and treating mental health conditions and maybe even fatigue. Malnutrition, again, associated with increased risk for long COVID. And we just need more RCTs to understand any of the causation and have good theories behind why we think different nutritional components are helpful with long COVID. I did mention a lot about PEA, so I wanted to give you, again, this is another set of foods that it's high in soy lecithin. Soy tends to be very high in PEA. I had mentioned coffee earlier. So is peanuts and are high. I don't think we eat much alfalfa, but wheat flour also. Then you can see the rest. These are the papers I reviewed in this presentation. And that's all, folks, if you remember those old cartoons. So I'm really happy to take questions. I'm going to stop sharing the screen, but if you need me to share and go back to a slide, I'm more than happy to do that.
Okay, wonderful. Thank you so much. We'll see, give it a minute, see if anybody has any questions. Let's see. No, I'm not seeing anything come up right now. Of course, if something comes up later, you can always try to get in touch with me and I can get in touch with Dr. Taren to figure some things out. So we'll go ahead and give you back some of your time for today. Thank you again, Dr. Taren, for joining us today. And then remember to complete your evaluation form so that you can get credit for today's session. And then if you're interested, our next session is on March 10th, and the topic that day will be proteomics. I hope I pronounced that right, and long COVID. So have a good day, and we hope to see you there.
Thank you very much, Dr. Taren.
Thank you for being here.
Great work. A lot of good detail and a lot of important caveats for us to remember when we're looking at data.
And maybe we'll keep going because I'm going to say that I gave this presentation earlier to another long COVID group that we were on a CDC grant doing actually a RCT on echoes to know if echoes were better than traditional education. This was with the University of New Mexico, and it was out of San Diego at FQHC in San Diego. And the interesting thing about this project was that we had lots of people with lived experience with long COVID. And the idea of like preparing meals, actually these are like controlled trials where you're giving it, when you're telling someone that they're having a hard time even getting out of bed to make themselves breakfast, you have to think about how to apply some of these nutritional concepts in the way your patients are living and struggling. And so it seemed almost, as I said, it was very accurate. You give them this is what happened. You give them this is what happened. But there's a lot more going on with this. And since you all are looking at long COVID echo, you truly understand all those issues that are happening. And it's just, I think I learned so much from the people who had lived experience in this project. And you may know there's actually a WhatsApp group on long COVID that came out of that project.
Did not know that.
You did, is still the grant's over, but still very active.
Okay.
And
well, actually, you know what? I think I might have known that. I forgot.
Okay.
I think the New Mexico team let us know about that. But yeah, that may be something important for us to make sure that our advocates, our patient advocates, are aware of as well if they're not already, part of that group. So, okay, yeah, very good. Well, thank you again for presenting. Again, this really important work. And we're here at the medical school, right? We want to be scientific and do randomized controlled trials, all that. But I mean, this is a very complicated real world study that is in a very imperfect, there's just, so just from that academic lens, it would be very difficult actually given so many factors, you couldn't possibly have enough subjects and do it, in a respectful, ethical way to
well, I do think I agree. It's not a purpose. I'm not trying to say do more study. I know new studies have to be done, but when you have a patient in front of you, you're not thinking about doing a study. Actually, I gotta think I had a former dean at Arizona. He was a cardiologist, but he used to always say, every time you treat someone with cancer, it's an experiment. I mean, we're talking about 20, 30 years ago.
Right.
You really didn't know what would happen, even though the studies say, do this therapy, this chemotherapy, this radiation therapy. So every patient's a new experiment.
Mhm.
And I think that when you think about patients with long COVID and you think about nutrition, I mean, they're being treated, maybe with a psychologist, maybe you're doing some respiratory problems for those who have POTS and things of these pieces. But then you say, well, maybe, maybe you should take vitamin D if you're, having some depression, or maybe you should, and you can start off slow and see how it happens, but always think about not doing harm. That's the Hippocratic way of doing things.
Key, right.
But there are things to try, especially the smell. You talk probably to your specialists who know about this. They may know about these are the types of intervention to do. And the other thing I learned a lot about was, use your referral network. If you're a primary care provider, lean on those experts who can help you with certain conditions. Because I think that's a lot of the conditions are just the conditions, even though it was initiated by long COVID, you still treat the symptom as the symptom.
Sure.
Okay.
All right. Thanks everyone for joining.
Okay. Take care.
See you next
Thank you.
time.
All right.
Thank you.
Have a good evening.
You too.